Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, evidence-based perioperative medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm here at the World Congress of Anesthesiologists in Marrakesh in Morocco. And I'm joined by my wonderful co-host, Professor Kate Leslie.
Hello, Andy. How are you going?
Really good. There's over 4,000 people here, I believe, at this huge event. 130 countries represented. It's huge. And we've been at the opening ceremony this morning, haven't we? It's a huge, full lecture theatre. People were literally standing room only. You know, awards being given out to distinguished anesthesiologists, rising stars, Moroccan dancers. Had it all.
The best part about it was that Desiree Chappell was the MC of the event. She was our managing editor till very recently, one of the founding editors-in-chief of Top Med Talk. And she is just made for a big auditorium stage, isn't she, Andy? Fantastic.
I was impressed by her French. I didn't know she could speak French, but she did that very well in the session. Great way to open a big meeting like this with really fantastic speakers.
And to honour amazing people like Angela Enright and Adrian Gelb, who've done so much in low and middle income countries, but also on the international stage at the WHO.
It's quite moving to see, well, they were moved, but how emotional they got with the video messages that were played from their family and their colleagues and saying, well done on such a huge achievement.
I said to you during it, I always tear up during those very polished videos of inspiring things. I'm a bit silly about that.
Yeah, it was great. It was nice. Anyway, we should move on to today's Top Med Talk podcast. And we're really, really fortunate and lucky to have two fantastic speakers who are speaking later in the conference about the high-risk patient. So, Debra, Duminda, do you want to introduce yourselves to our listeners for us?
So, my name's Debra Leung. I'm a full-time anaesthetist at the Peter MacCallum Cancer Centre in Melbourne, Australia. I got involved in sort of discussions about high-risk patients because I established and lead a shared decision-making service for high-risk surgical patients. And through that, I've sort of extended that into a research interest, and I'm currently finishing up a PhD looking at the role of shared decision-making for high-risk surgical patients.
Duminda Wijeysundera. I'm a full-time clinical anesthesiologist at St. Michael's Hospital in Toronto and a professor of anesthesiology and pain medicine at the University of Toronto. I've had a research and clinical interest in high-risk patients. I did internal medicine before I did anesthesiology, so a lot of my interests pertain to the intersection of the two. I have a clinical interest and research interest in how do you manage medically complex patients who face surgery and want to have a good recovery afterwards, how to identify them better and how to actually make that happen for them.
First thing to think about is what we're meaning when we say the high-risk patient.
High risk is a simple descriptor for a very complex construct in many ways, because, risk is inherently tied to risk of what exactly. As you know, both of us are giving talks in a common session later, is what series of adverse events are patients at high risk for? And traditionally, we've thought of mortality, which admittedly, through, I think, successful improvement in general care, doesn't actually occur very often. I think people underestimate or overestimate how mortality risks are in general for elective major surgery in middle-income and high-income countries. It's about 2%. So 98% of patients survive, which is good. But I think there's a lot of other things that we need to characterize and inform patients of and manage around. And so I think it's risk of those other things. And so I think of patients who are at high risk for complications, major medical morbidity, and a particular interest of mine, because I think we under-recognize it and patients prioritize it, is return to function and return to independence, which is very important to patients, even younger patients, but especially older adults. We just don't incorporate that a lot into our discussions or decision making. So I think patients are at risk for those types of events.
Yeah. And to build on that, I'd say that I would echo what Duminda said, which is that risk is so multifaceted. And I think we're now realizing that we have to move beyond sort of the traditional constructs of just clinical risk. We know that risk is inherently personal for patients. And so I think now we're really sort of now doing more research and looking more at sort of those hidden aspects of risk, because there is clinical risk, but there is also psychosocial risk and personal risk that needs to be taken into account and all of that. And I think our perioperative care is now working out how we can encompass and more fully measure those other sorts of sort of hidden risks as well.
So, Deb, when you're in your clinic, can you describe a typical encounter with a patient, say, who's coming for a major cancer resection? They come in and say, hi, I'm Dr. Leung or Deb, and what happens next?
There's a lot of work that actually happens before the patient comes into clinic, because there's clearly a huge amount of work to sort of triage these patients into these clinics and to work out what their decisional support needs are. So really sort of before the patient even walks into the room, we have to work out why they're coming to our shared decision-making service. And it could be because they have decisional conflict and they're not sure if surgery is the right decision for them. It could be the clinicians who are caring for them have expressed concern about whether surgery might be beneficial and an appropriate treatment option for them. And so there's a lot of preparation that goes into it in trying to sort of really work out what the clinical decision-making aspects of contemplating surgery are before the patient gets into the room. And then once we get into the room, there's a huge piece of work actually in trying to really discuss what shared decision-making actually is with patients and why it's important for them to get involved. Because usually prior to them actually coming to the clinic, although we have information available in digital and paper forms to try and prepare patients to engage in this process, most of them actually walk in not really having any idea of what shared decision-making is, or actually even at that fundamentally surgery or to have surgery is an explicit choice. And I think that's actually the very first most fundamental step of shared decision-making, is the recognition by the clinicians and the patients that actually surgery is an explicit choice. So we spend a lot of time sort of actually outlining what the process is and then trying to then personalize the process so that patients are engaged as much as they want to be in the shared decision-making process, recognizing that not all patients want to be involved to the same degree. So really that first part is about explaining what it is, trying to personalize the rest of the consult to the patient, and then the rest of the patient really is about trying to work out what the patient's values and goals are, what they're trying to get out of their treatment, what they'd like to get out of their life for the next 5, 10, 15 years, and then trying to match that very personal information to the clinical information that we have as medical experts to try and then come up with ultimately a goal congruent treatment decision about whether surgery is beneficial and likely to help them achieve what they would want to.
This is not something that anesthesiologists are generally taught how to do. I mean, it sounds more like career advice or psychotherapy or, you know, a talking job. How are we going to train anesthesiologists to do this work? Because I think implicitly having you here, we believe that it's an anesthesiology role, at least in part.
Implementation and training is really going to be the next big sort of research and clinical question for us in this field. Really up until now, it's very much an emerging field. And I think we've only really now started to grasp sort of from an operational point of view what shared decision-making is as an intervention and how do we actually work together with patients to bring about this process. And so I think you're right that there is a huge amount of work to be done in sort of working out how, as clinicians, do we prepare ourselves to deliver this intervention as effectively as we can be. There's sort of knowledge aspects to it and there's probably experiential aspects to it. So I think the knowledge aspects are really about trying to, now that we've come up with sort of more of a standardized operational definition for shared decision-making, looking at how we can implement it consistently throughout different healthcare contexts so that we know that we're implementing the same type of intervention, because up until now it's been very variably delivered. And I think once we have those sort of knowledge aspects and we're all doing the same thing, then the experiential aspects really has to focus on communication skills training. And that is something that is really fundamental to delivering shared decision-making effectively.
Duminda, to come back to your point about complications, does that come into the shared decision conversation as well, or is that a separate facet to this?
You know, there's been work that's been done in terms of asking patients what events do you prioritize in either achieving or avoiding. And there's been work from Canada, from one of my colleagues at the University of Ottawa, who showed if you look at older adults, things that they prioritize aside from obviously avoid survival is avoidance of complications, but also regaining independence. So we know that that is one of the events that they highly prioritize. But I think the focus on returning to a level of function, which I think Debra was describing, is very important. And in a study that I always tell people about when they ask about this is a famous study by Frieda and colleagues, which was published about 20 years ago in the New England Journal of Medicine. They took a few hundred older adults who had life-limiting conditions and they presented them with a number of hypothetical interventions to extend their life. And these interventions could be major or minor, something like surgery, which is major, or an ICU admission, and associated risks. And what you found was people would accept risks of mortality exceeding 50% before they even budged on declining that. But when they talked about cognitive decline or functional decline, they started refusing far earlier. So I think complications are important, but I think the degree to which we can connect that to function and a meaningful life, that's, I think, the most important part that we have to do. But maybe, Debra, maybe a question for you would be, how did you get your hospital and the surgeons to accept that, because that's often, I'd say these are one of the things. We have skill sets that we have to train. I'll admit there's some people who enter anesthesia because you want to minimize your conversation. Why there's only some of us who do chronic pain versus some of us who don't. But the other part is simply structural. I'll give you a simple example that at one of the hospitals I used to work at, where there was a geriatrician who started providing shared decision-making or consultation services to people having major head and neck cancer. And a few things that were observed was a rate of dementia that they had that was not recognized. They didn't understand what they were signing up for. And about 25% of them decided not to proceed. What's interesting is 6 months into it, the surgeon said, we should just stop doing this. Because the incentive system, the culture of surgery, and almost the financial structure of how hospitals are structured kind of overrides that. And so how did you manage to overcome that? I mean, there may be some unique advantages of Peter Mac and the Australian system, but I found that to be often the biggest barrier. We have some surgeons who are really interested and we can have these conversations. And we've had cases where we chose non-operative approaches, but that's been the biggest challenge to even getting to the starting point of that discussion.
Absolutely. And I think we've actually done some work that's just in pre-publication at the moment, where when we surveyed all of the shared decision-making services around Australia and New Zealand, the highest sort of barrier to implementation was engagement, and particularly engagement by our surgical colleagues. And so that's certainly an important factor to consider. What we were finding, and I think that the issue is probably highlighted or focused within the Surgical Oncology Centre, is that increasingly we were finding that both patients and clinicians, sometimes surgical decisions were sitting uncomfortably with us. You know, we've all seen those patients on the wards or in the intensive care afterwards who have done badly or have had poor functional outcomes after surgery. And we knew that to a large extent this was predictable. And so a lot of the patients and nurses, ward staff, everyone looking after these patients would often ask these uncomfortable questions, which is, were these conversations had with the patient beforehand? Did they understand that this is what they were in for? And if they knew that, would they still have made the same decision or not? And so I think that feeling was sort of enhancing. And so we felt that we needed to do something about it. And we know, exactly as you said, that a lot of these conversations actually happen all the time. A lot of us are doing those conversations. A lot of very good clinicians, very good surgeons, very patient-centered care is happening out there. But the problem is that there's a huge amount of variability in how and when these conversations are happening. They're often corridor conversations. They're often one surgeon saying to the anaesthetist, are we really sure about this? And then you send them to PAC, and then the anaesthetist and PAC is someone different, and they say, oh, well, the surgeon obviously sent them here, so they think it's probably reasonable. And everyone's sort of asking these same questions, but there's no structural framework around it. And so shared decision-making really helps to bridge that personal tension that might be in people's heads about whether, patients are fully engaged in these decisions, and really tries to lay structure and framework over these corridor conversations that we're having already. So it was difficult at the start, but once we started to get patient engagement, and we were very selective about the types of patients that we initially brought into our service, and we did try and identify surgical streams that had surgical champions, because you do need surgical buy-in, and to do these processes in isolation, I think, is folly. It's really very much a team sport, and you need the engagement of all the experts, including the patient, to make this successful. And so we really tried to sort of leverage that and choose surgical champions who we knew were on board, work with their patients. And then once more and more surgeons started to see the benefits to the patients, but also to them as clinicians as well, and to all the staff looking after patients, we really started to get more and more buy-in until it sort of became embedded within our normal sort of perioperative processes.
Duminda, how do you talk to patients about risk? We've got patients from all different backgrounds. Here at the World Congress, we've got people from all over the world who've got different health literacy and different expectations about healthcare. But back in Canada, back in Toronto, what sort of language do you use? How do you convey risk to people? Because afterwards people go, but you said this was only going to happen to 1 in 100 people. And it's like, well, sorry, you're the 1 in 100 person. What do you do? What's your advice to our listeners?
So I think a few things. So one is even how you convey numbers, because if I were to say 1% or 2%, people don't really understand what that is. And I often say, as you did exactly, for every 100 people who are like you, who have this operation, I would expect X things to happen. I do say that and give them time to just reflect on that and just ask questions if they want. I try to use language that is, I think, meaningful to patients. So if you just tell them myocardial injury, they're like, what is that? So, you would use language like a small heart attack or, severe damage to your kidneys where you might require dialysis, things that are meaningful to them. And I try to be selective about what I tell them, because not because I'm trying to hide anything, but sometimes it's easy just to overwhelm people with kind of things like, if I told them there's a 25% chance you'll have a small bump in your blood chemical indicating you had heart damage, they don't know what that means. It's hard to sort of frame that with some sort of reality they understand. So I try to focus on major events that they will experience, at least when I frame those numbers. The other thing I tell them is this average for a patient having this kind of operation? Because some operations are just big. I would tell them, if you're having your pancreas out, this is not an appendix procedure, right? So this is about that. It is a big operation, but you're lower than average. So they have a sense of where they rank. And I also tell them, is there anything we can do about it? Because sometimes they need to understand you're at elevated risk, but in truth, this is what it is. We're at the best state that there's no other tests, there are no other interventions. And if there's something we can do, I will tell them, because people want to understand, is this the best I can be going into the procedure? And if it is, that's how things are. And some of the things I often focus on with sort of older adults increasingly is, because we don't have a shared decision-making sort of process that's formalized, is I discuss things that they don't actually think about very much, and especially if they have family members. So I talk about how long it's going to take to return to function, that it will probably take 3 months to 6 months. That is not a short recovery period. And I tell them that's just normal. And you need to be prepared for this and for many of them, that's actually quite surprising, because they think it'll be a few weeks and they'll be up and doing stuff. I talk about delirium, which is often something that I would emphasize for patients, they are sometimes not aware of it, but it is very traumatic for family members. And I talk about cognitive decline, even temporary, things that are real, that we're aware of in our own field, but patients and families are often not aware of. And even if you can't reduce the risk of it in any meaningful way, they can prepare for it or be aware that it could happen. And I just let them ask questions afterwards. I think one of the things just touching on something you talked about earlier, Debra, was about the social risk. So one of the things that makes a lot of sense to us, and we've found that in one of our recent studies called Fit After Surgery, where we looked at risks of significant disability in new disability or worsened disability in older adults, is there were medical features that drove that. But one of the biggest things was poor social supports. So we all know the older adult or the person who lives without family in the city, who's estranged from their children, they don't have that kind of help. They're vulnerable. So I ask about that. And I talk to them about the need to figure out some supports. And I'd say our health system does not do a very good job of that. But I would say, these are opportunities for you to have discussions with your surgeons to assemble those social supports, even if they're government supported, in anticipation. Because I remember an example of someone who lived by themselves, who really didn't have many friends. And their major concern was who was going to take care of their dogs after surgery. And I was thinking, you need to worry about who needs to take care of you. But, those are the types of things I typically talk about.
I was thinking while you were talking that, as we move through life, we change all the time, and every day is a new normal, for our life, and all our experiences, both enhance and diminish us. But when we see patients before surgery, we promise them that they're going to be the same afterwards, and they're not going to be the same. They're going to be different, and they could be different in a better way or a worse way or just a different way. And that is such a difficult thing to convey. Like having major cancer surgery, Deb, it's a life-changing experience, isn't it?
Yeah, absolutely. And we often are quite explicit in that we actually say those words. We say this is potentially life-altering surgery. And as you said, drawing on what you said, there's an inherent amount of uncertainty in it as well. There's great work being done in perioperative risk assessment and prediction and all these sorts of things. And we need to do that work. That's fundamentally important work, but we need to pair that work in the data sphere of things with then work in models of care and how we make and translate those risks from sort of the clinical world into something that's meaningful for patients. And, exactly as Duminda was saying, there's a huge amount of evidence in the decision-making science world to show us that patients, even patients with very high health literacy and patients with very high general literacy, really struggle with probabilistic risk information. So you're saying even simple percentages are just like in the workshop that we were just doing then, we facetiously cover this paper that was published about meteorology, and they talk about 30% chance of rain. and they surveyed people all around the world on what does 30% chance of rain mean. And they got a huge variety of answers, including things like out of 100 grey clouds, it means 30 of them will rain that day, or 30% of the land will be covered in rain. They got a huge amount of different kinds of translations. So something even as simple as that kind of probability has a huge amount of sort of, interpretation behind it. And interestingly, it was also very geographically and culturally co-located. So people, based on their experience, tend to interpret risk in different ways. And so being able to really truly take the time to understand your patients, their life experience, and how that determines and influences and shapes how they make decisions is really important. And I think that's where shared decision making is sort of that bridge between that clinical decision making world and how we present risk as clinicians, to then helping support patients to make meaningful decisions about treatment decisions that are likely to bring about outcomes that they want to. Because fundamentally, when we talk about high risk, that's what the risk is. The biggest risk is that we do an intervention to a patient that doesn't, or is unlikely to give them an outcome that they're looking for. So, I think that's where the bridge is.
I just want to pivot back to something you've both touched on, and also partly from at least our experience in the UK. But my experience is these patients are increasing in number. Our patients in the UK are getting older, they're getting more comorbid. We're doing more high-risk procedures on these people. This is becoming an increasing percentage of our day-to-day working practice. And notwithstanding any of the things we've already talked about, which are clearly important, as you've both identified, we get to a point where we've had this conversation, we've discussed these risks, however we phrase them with the patient, and we come to some sort of mutual agreement or acceptance that this risk is there, and then we're going to go ahead and do something. What happens at that point? How do we then manage that risk that we've both agreed to take on, the patient and the clinician?
Well, I think that's why, I think, Debra, you've touched on this already. It's, a lot of our work, the work that's gone, there's a lot of risk prediction models. There's a lot of risk prediction tools. The advent of AI just means there's going to be thousands more papers that are going to do this. But risk prediction only has value when it's tied to some form of action. So shared decision making is one of them, but it is now to develop models of care that are matched to what those risks are. Because as I'll mention in my talk coming up, most patients, the demographics and characteristics of the surgical population are changing. But there's a certain segment of patients that just need high quality routine care. But there's going to be this increasing segment which doesn't. It's going to need more. And I think it's to develop pathways that are appropriate to that. But it goes down with what do we offer them? It depends. This may mean that we had to think about increasing prehabilitation services where that is appropriate and driving investment to that and convincing funders to do that. It may change the way we need to manage things in the operating room. Though in truth, we can identify patients at a high risk, but the amount of compelling data that show that we can decrease that risk is much, much lower for the thousands of patients that have been involved in trials. So part of it could be we've been framing interventions incorrectly, that we may need bundles. We may simply have included the inappropriate groups of patients. Pragmatic trials include everybody, but this idea treatments have common treatment effects consistently across risk profiles may be true for hypertension. I don't quite believe that for the surgical population. I think heterogeneity of treatment effects is real. It's just we haven't explored it well enough. We need more research in that area. But I think even then, we have to do stuff without full evidence. So I think it's to develop care pathways for those patients. We could be better monitoring, different blood pressure targets, prioritization of critical care, and really enhance postoperative recovery. So not just prehab, but post-hab, if that's what it is. That's what we need to do. We don't have that organized in most settings because we've not thought about it, I think, is in that kind of structured way. But if we think about the changing demographics of patients, if we're going to offer surgery to them, which we ought to, for patients who willingly accept that, we need to develop structures of care that are based around that. I think that's what has to happen. It happens way too much in an ad hoc fashion right now because there are some of us, we know all colleagues, who will think of all of these things and advocate for that, and others who'd say, our job was to make sure you're fasted and you're easy to intubate. That variability just doesn't work.
I think it's really about identifying which parts of risk are modifiable and which parts of risk are non-modifiable. And I think, as with all of those innovations that Duminda was talking about, obviously the threshold of what risk is modifiable is sort of slowly going to be increasing and increase. But we also have to similarly recognize the counterpoint, which is that as technically we're able to offer more complex surgery to frailer and more multi-morbid patients, and as our population demographics change, we're going to experience an increasing sort of surge of patients where no matter how good our prehabilitation, our rescue strategies, our identification of people at risk of these sort of deteriorations are, there's going to be a number of patients and a growing number of them where the degree of risk is non-modifiable. And so we have to have in parallel structures to try and address modifiable risk, but also models of care and frameworks that help us manage that increasing amount of non-modifiable risk there. So it really goes hand in hand, I think. And that's why I think those prehabilitation and shared decision-making kind of models tend to really complement each other. And that's often why they tend to be co-located.
Completely agree. I think we should probably round it to a close on that. Thank you both for a really thought-provoking conversation.
Thank you.
I'll remember that weather analogy for a long time. Perfect.
But that's not good enough for golfers, Deb.
No, that's
you
right.
You need
that's
it more
exactly
specific.
Right.
Well, thank you both for your time. Thank you for a really inspiring conversation. As always, you can hear this conversation and all our other podcasts on topmedtalk.com through your podcaster of choice, whatever means that is, and on all the main social media channels. If you do find us on social media, please do hit like, hit subscribe. It really makes a difference to us. A huge thank you to our fantastic sponsors who keep us free and open access around the world online. That's BD and GE this year. And a huge thank you to the World Congress of Anesthesiologists for hosting us here in the wonderful Marrakesh.
Thank you.
Top Med Talk.
Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org. That's ebpom.org.